Okay, I guess I'll get started now. My name is Tara McMullen, and I am a health analyst at the Centers for Medicare and Medicaid Services, CMS. And today I am with my colleague Kimberly Schwartz, moderating the next symposium, which is on screening and detection. Screening and detection is such an important issue, specifically speaking to elder maltreatment, as there is no universal agreement to how to measure or how to screen elder maltreatment itself, due to multiple issues, as we heard in our last symposium, culture, cohorts, regions. So there's a lot of variation, and we're very interested in how to basically disentangle the barriers and basically expand upon the measurement aspect of elder maltreatment and the assessment aspect of elder maltreatment. So with that said, Kimberly and I will present today on the CMS Elder Maltreatment Quality Initiative, and we have two speakers as well. We have Dr. Mark Yaffe and Dr. Scott Beach that will be discussing their personal work with measurement and assessment, and then we will have questions. So first, again, we're going to discuss the CMS Elder Maltreatment Quality Measurement Initiative. And essentially, as we all know, elder maltreatment is a multifaceted issue. It affects many providers, many individuals in multiple settings. It's widespread. And that evidence itself in early detection for older adults is insufficient. And we can even extend that to the measurement of elder maltreatment itself is insufficient. There's no universal agreement on how to measure all aspects of elder maltreatment. So CMS is interested in expanding its membership or its measurement base and also its assessment base, looking at older adults and assessing abusive situations in multiple settings. And so to begin, we had an environmental scan with our contractor, Quality Insights, who's represented here today. So thank you to them. And there are multiple findings from this environmental scan. One finding was that there currently is no reliable or valid screening tool to identify elder abuse, elder maltreatment, specifically in vulnerable adults. And this caught CMS's eye as this specific finding came from the U.S. Preventative Service Task Force, and they focused on reliable screenings in primary care populations. At the moment, the greater proportion of elder maltreatment measures that CMS holds that we've developed are in primary care populations. So this is something that needs to be focused on. Furthermore, CMS is currently attempting to harmonize most of our measures from the primary care population to the home and community-based care population, and even to the acute care population. So better understanding why there's no agreement on the reliability of current assessments and even that of measurements is important to us. So with that said, we began in 2012 our CMS Elder Maltreatment Initiative. And essentially what we were attempting to do in this initiative is to understand the reporting, the screening of this topic, and even that of how to expand measurement between settings. We began this initiative looking at our PQRS, which stands for our Physician Quality Reporting Systems measure, which looks at screening. It's NQF endorsed 181. And so we began to evaluate this measure for appropriateness and attempted to assess this measure to see if we can expand this measure out into first a post-acute care setting, that of SNFs or nursing homes, depending on what population you want to look at. So by focusing on the PQRS measure, we assembled national experts to sit in 3 different groups to assess how we can expand this measure, how we can include an assessment in this measure, and how we can better define elder maltreatment to guide measurement development. And it should be noted that Dr. Dong was on a leading force and helped with Quality Insights to guide our committee to a symposium that we had last month. So in that symposium, we discussed the first phase of what our 3 groups have found. We're now currently going into phase 2. So today's presentation will be about these findings. And I'm going to turn it over to begin discussing our physician quality measurement with Kim Schwartz, and then we'll move into our 3 group findings.
Hi, thank you very much. So initially, I'd like to just go over, currently we have the measure within the Physician Quality Reporting Program. And the measure specifically is for patients age 65 and greater that we're screening for elder maltreatment at least once in a reporting period. That reporting period is typically identified as once in a calendar year, that being from January 1st to December 31st. A follow-up plan should be documented, and the challenges that we've identified with our current measure is that it's seldom reported by eligible providers, and we have an intention to obviously improve the feasibility of reporting this measure. In terms of screening for elder maltreatment, the elder maltreatment screen includes assessment and documentation of all of the following components, many of which we have discussed today: physical abuse, emotional or psychological abuse, neglect, sexual abuse, elder abandonment, financial or material exploitation, self-neglect, and unwarranted control. In terms of the follow-up plan, it may include, but is not limited to, documentation of a referral or discussion with other providers, ongoing monitoring or assessment, and/or a direct intervention. Not eligible would be a patient that, for one or the more of the following conditions exists: perhaps the patient refuses to participate, or the patient is an urgent or emergent situation where time is of the essence, and to delay treatment would jeopardize the patient's health status. Overall, statistically, we had over 53 million total denominator applicable cases for this measure. We had 21,000 total denominator applicable cases for participating providers. We had 1,438 total quality data codes reported on the applicable cases. And that basically broke down to 133 people, providers that participated reporting this measure. So although we show a performance rate of at least 90%, and statistically it shows a good outcome in reporting, it's based upon obviously the numbers, and the numbers reflect a very small margin of eligible providers that can report on this measure. And that is basically the main concern of CMS in terms of encouraging reporting, because we realize in reporting this measure, it's kind of, in a sense, opening up Pandora's box, because then the provider is obligated to follow through on the necessary steps if they do actually identify that, some form of maltreatment is occurring. Those reporting for the measure currently for 2013 are counselor and psychologists, family practice, geriatrics, internal medicine, other eligible professionals, PT, OT, psychiatry, urology, and it's actually in the Welcome to Medicare initial visit. We recognize that in expanding the measure, we need to expand across populations of providers as well as areas that we want the measure to be reached out to. So in essence, when we gathered for the symposium and prior to and conducting these weekly meetings, we were identifying the structures and the priorities that we wish to have in this new measure development. So as we stated, the current measure, in terms of the encounter and billing codes, we have the eligible providers that can report. Our goal in terms of the new measure is to have cross-cutting, to increase screening efforts, to include inpatient, to include nursing homes, assisted living, dentists, ophthalmologists, other areas where, maybe that person only gets out to see a particular provider once a year. Maybe that happens to be, the dentist or the ophthalmologist. So we really feel like this measure needs to reach across all care settings. The current measure, as stated, is reported once per measurement period as identified, and that's a calendar year. But we feel like from a new measure recommendation, what came away from our various meetings was that each visit needs to be considered. Trust may not be developed, and the patient may not report on the first assessment or the first time that they actually see their provider. And a patient's situation obviously changes. The current measure, as identified, we have 8 components. We feel like that can be a bit burdensome to a provider, especially when you have a whole waiting room full of people to deal with. From a new measure perspective, we feel like use of a screening tool would be more feasible, which Tara will get into later, and should reference to cultural specific screening tools also need to be addressed and identified. The current measure, there's no clear guidance for response to a positive screen. The new measure standardized the intervention, includes specific language versus an algorithm, and we want to obviously be able to contact APS, which we know from a state to state that kind of varies. Current measure, we have no listing of resources. With the new measure, we want a list of resources to adjust to the needs of the patient. And in terms of follow-up direction for a positive screen, we'd like to be able to list an agency to list a follow-up plan to be followed specifically for those providers as well as for the caregiver. Future measure development, we'd like to have a more in-depth screening process, perhaps a two-tier process, self-neglect screening, at-risk screening, and follow-up care measures. And I'll turn it back over to Tara to discuss the screening tools for elder maltreatment.
So in developing a screening, we find that we have measurements available at CMS to basically measure abuse itself, and that way we relate that to quality. But we understand that we need to have an assessment to help guide that measurement. And with our groups, we have looked at assessment tools and basically devised a way that we can insert and instill an assessment. So going through multiple assessments that are currently used, I believe this group looked internationally at multiple assessments that are used in different cultures, used in different regions, look at basically different types of abuse, whether that's physical or emotional. The one thing that this group found, and it should be noted that this group was led by Dr. Decker and Erica Smith from DOJ, the one thing that this group found was that there may be burden on the individual in terms of assessment. Assessments tend to be multiple questions in length. They all do not ask the same questions. They're not aiming at the same goal. The specifications of the assessments are different. They look at different cohorts. Usability may be difficult. They focus on different questions. So it's a fluid process, but it was difficult for this group to disentangle everything based on just the multitudes of different types of assessments. So after doing a lot of work, this group has decided that an assessment, there should be no one assessment that should be used for measurement, that CMS should not focus on an assessment, that we should use a variety of assessments and to basically create a global assessment, assessing for different types of abuse in different situations. So this group has decided on 3 different types of tools. You'll see the EASY, the VAS, and the HS East. And the HS East was mentioned in the last symposium presentation. And essentially, these tools look at older adults' physical situations, psychological, emotional, neglectful situations, financial, and sexual abuse. At this time, and which I'll get to in a second, it's very difficult to assess what type of abusive situations that we want to focus on since there's so many. You heard in the last symposium, there's cultural issues and there's spiritual issues. So at the moment, this group felt that focusing on these issues for an assessment tool would be feasible. So again, it would not be one of these. It wouldn't just be the EASY. It wouldn't just be the VAS. It would be a collection to make a global assessment. Then the question of validation and reliability, it always comes up with CMS as many of our measures we have to bring to the National Quality Forum for endorsement. And so this would be a part of the endorsement cycle. And basically what this slide is illuminating to you is that these 3 assessment tools have been shown to be valid within the prospective testing settings. And finally, to guide the measurement and the assessment of elder maltreatment, we have a group led by myself and Andy Mao, the DOJ, that looks at defining elder maltreatment to guide the development of measurement. And basically, this group set out to explore, to make a comprehensive definition of elder maltreatment. We've actually tailed back that objective to make this a comprehensive definition of elder maltreatment for this initiative, as it's very difficult to basically assess elder maltreatment globally. There's no standardized definition of elder abuse itself. And what we're doing in this group is basically we're starting with interagency. We're looking at all the definitions of elder maltreatment between agencies. We're going to conduct a thematic analysis, and we're going to, from that thematic analysis, make a definition of elder maltreatment that will guide this initiative. Our long-term goal is to maybe have the agencies within HHS adopt this definition, and maybe we can find a starting point to agree on what is elder maltreatment from there. I know my time's almost out. I just have 2 quick slides to show you the differentiation between in HHS right now, how different agencies are defining abuse. You have the CDC, which says that abuse is physical, sexual, psychological, and emotional. it's neglect, abandonment, and financial. And then the AOA suggests that it's domestic, institutional, self-neglect, or self-abuse. And as they are reoccurring themes that cross-sect each other between those two definitions, you'll notice that there's variation. And in lack of time, if you want to see the slides, I have additional slides on this, but every agency defines abuse differently, or they don't define abuse at all. So right now, the attempt is to create a definition that will help guide measurement and assessment for CMS, and the long-term goal is to expand out from there. Thank you. And now we will have Dr. Yaffe discuss his research and screening.